Good afternoon. Welcome to the Global Interdependence Center's final executive briefing for the year. I'm Kathleen Stephansen, your host for today and also the GIC board chair. Today, we will explore the role nurses continuously play in the fight against COVID-19 and how nursing curriculum might have changed as a result of the pandemic. I'm pleased to announce that today's event, as well as many other events that we've had over the past few months, is part of the David R. Kotok Global Healthcare Series. And on behalf of everyone at the GIC, I would like to express our appreciation and thanks to David for his generosity. As a reminder, this event is going to be recorded, and the replay, as well as the slides that you will see throughout the presentations, will be available on the GIC website. So joining us today, we have two top professionals in the nursing field, Rayna Letourneau and Shelly Schwedhelm. Dr. Rayna Letourneau is an assistant professor at the University of South Florida College of Nursing, and she earned her Bachelor of Science in Nursing and her Master's of Science in Nursing Administration from the University of Rhode Island back in 2002 and 2008, respectively. Her research focuses really on nursing workforce development, transition to practice, and quality and safety education for nurses. Rayna has 10 years of teaching experience on both the undergraduate and graduate level. Shelly Schwedhelm is the Executive Director of Emergency Management and Biopreparedness at Nebraska Medicine. Shelly is also an Executive Director at UNMC Global Center for Health Security and is the current chairperson of the Board of Directors for the Omaha Metropolitan Healthcare Coalition. Shelly had overall accountability for unit operations and logistics during the care of repatriated Americans with Ebola virus disease, and that's back in 2014 and 2015. And this year, she led efforts to support quarantine missions for repatriated Americans from both China and Japan. So, with these two introductions, it is really time to jump into today's discussion. And I will turn the virtual stage, if you will, over to our first presenter, and that is Rayna. Rayna, welcome to the GIC.
Thank you. Thank you for my introduction, and thank you for having me. I'd like to start by familiarizing our audience to the nursing profession. I understand that our audience members are from diverse industry, and not all may be familiar with the nursing industry specifically or healthcare industry. So Colleen, if you can advance to my first slide. Thank you. Let's start by looking at the demographic characteristics of the nursing workforce. There are approximately 4.6 million registered nurses, or RNs, in the United States. The majority of RNs are baccalaureate prepared. However, we did not meet our goal of achieving 80% baccalaureate prepared nurses by 2020, as recommended 10 years ago by the Institute of Medicine, now known as the National Academy of Medicine. More than half of all nurses work in hospital settings. Next slide, please, Colleen. You can see here by the numbers that nursing is not a very diverse profession. The majority of nurses are white females. We have a lot of work to do in order to increase the diversity in nursing so that nurses will mirror the population they serve. But we are making progress largely because of the Future of Nursing Campaign for Action, which is backed by AARP, the AARP Foundation, and the Robert Wood Johnson Foundation. The Campaign for Action reports the number of minority students enrolled in nursing education is increasing, as is the number of men in nursing. Go ahead, Colleen. For the 18th year in a row, the honesty and ethics of nurses are rated highest among a list of professions that Gallup asks Americans to assess annually. Nurses are caring and empathetic. We are resilient. We are aware of situations. We are aware of the behaviors around us, and we are aware of our actions so that we can maintain control of situations. We solve problems using critical thinking and critical reasoning skills, and we advocate for our patients to maintain safety and quality of care. Next slide. So you may be asking, what do nurses actually do? Well, we do a lot of things very well, and we do some things not so well. So let's begin with examples of things that we do well. Nurses are responsible for assessing their patients or the populations that we serve. We conduct diagnostic tests, provide patient education, safely administer medication, and most importantly, we promote health and wellness. On the other end of the spectrum, when we think about what nurses do not do very well, we can identify self-care. Generally, nurses do not care for themselves as well as they care for others. According to a survey from the American Nurses Association, 68% of nurses reported putting the health, safety, and wellness of their patients before their own health, safety, or wellness. Next slide, please. Research shows that nurses have higher body mass index, or BMI, compared to an average American. Nurses have higher levels of stress than the average American, get less sleep, and work longer hours. The data that I'm reporting in this presentation is from the American Nurses Association's Health Risk Appraisal. The Health Risk Appraisal was a survey administered to registered nurses and student nurses between 2013 and 2016. More than 10,000 participants completed this survey, and the data tells us that nurses are not healthy overall. The stress, the work shift demands, poor nutrition, poor exercise practices all contribute to a growing and serious issue for our profession and for our patients. 50% of nurses experience burnout. Burnout is defined as, or it's comprised of emotional exhaustion. It could be depersonalization, reduced personal accomplishments. Nurses suffering from burnout may experience physical symptoms such as headaches, insomnia, anger, fear, impaired memory, and decreased attention. Nurses may even have thoughts of quitting their jobs. So burnout and depression can lead to, unfortunately, drug and alcohol use and suicide. The CDC reports that suicide is the 10th leading cause of death in the US. Alarmingly, nurses have a higher risk of suicide than the general population. Next slide, please, Colleen. Other considerations to the health and wellness of nurses are hazards such as workplace violence and musculoskeletal injuries. These hazards are contributing factors to poorer health of the nurses. According to the Bureau of Labor and Statistics, registered nurses have the 4th highest rate of injuries and illnesses that result in days away from work when compared to all other occupations. Next slide, please, Colleen. So now let's talk about how COVID-19 has impacted the health and wellness of nurses. The COVID-19 pandemic has impacted a nursing workforce that is already experiencing widespread stress, health and wellness problems, burnout, depression, and increased risk of suicide. In April of this year, the International Council of Nurses reported that, and I quote, There is strong evidence that nurses are experiencing unprecedented levels of stress. And then the council goes on to say that nurses are at high risk for full-blown stress response syndromes, anxiety, depression, post-traumatic stress disorder, chronic illness, and burnout. And that's the end of the quote. Our nursing profession realizes that the bad is getting worse. For example, nurses who typically work 3 12-hour shifts per week are now expected to work 5 or 6 12 to 16-hour shifts per week. Hospital-based nurses are fearful of workplace exposure to COVID-19 because they are the providers of direct patient care. The CDC recently reported that 36% of healthcare workers hospitalized with COVID-19 are from the nursing workforce. And on November 23rd, just last month, the nation's largest nursing union, National Nurses United, reported that at least 253 registered nurses have died as a result of COVID-19. So this is a problem that cannot be ignored. The health and wellness of nurses must be addressed. A strong nursing workforce is essential to the healthcare industry and to the health and wellness of our nation. Next slide, please, Colleen. So that brings me to discussing nursing academia and what role does academia play in response to COVID-19? Or what is academia doing as a result of the pandemic? Next slide, please, Colleen. So I will start by first saying nursing academia is ensuring that future nurses will be prepared to enter the healthcare industry and the nursing workforce. Nursing faculty asked ourselves, what needs to happen so that future nurses will be safe, confident, and competent? We asked, what can we do to enhance an already rigorous curriculum? So here are a few examples of curricular enhancements in response to the current state of the healthcare industry and the pandemic. We added content related to COVID-19 to the curriculum. The content builds in complexity as students progress to higher levels of the nursing program. We have implemented innovative teaching and learning strategies that focus on quality and safety competencies to increase students' confidence and competence. We are promoting self-care because we know that students' health and wellness can affect their academic performance, just as nurses' health and wellness can affect patient outcomes. And lastly, we are including mentorship into the programs. Mentorship is needed now more than ever. Students can be mentored by faculty, or they can even be mentored by their peers. Next slide, please, Colleen. I'd like to take just a minute to give an exemplar of an innovative teaching and learning strategy that we implemented at the University of South Florida in response to the pandemic. The COVID-19 pandemic suspended clinical experiences with direct patient care for our nursing students at USF and across the country. Many hospitals, healthcare facilities, and schools of nursing determined that students should not be in contact with patients. However, clinical experiences with direct patient care are a mandated part of the curriculum. Students would be unable to progress in their programs and potentially not graduate on time without these clinical experiences. So the USF College of Nursing formalized a collaborative partnership with Trumont, which is a nurse-led company, to provide a virtual clinical practicum experience to our senior level nursing students and ensure that they would meet pre-licensure program outcomes. We wanted to ensure they would graduate on time and enter the nursing workforce. The practicum offers an evidence-based curriculum consistent with the work of the Institute of Medicine, the Robert Wood Johnson Foundation, and the National Council of State Boards of Nursing Regulations, and it gives students an opportunity to demonstrate knowledge application and decision-making while in the role of a nurse. Evaluation data demonstrated that the practicum increased students' confidence and competence, and the data supports making the practicum a permanent part of the curriculum. Next slide, please, Colleen. And here are just some examples of evaluation strategies that we used on the practicum. We surveyed students. Did they feel that this practicum was increasing their confidence? Did it make them feel more confident in their practice? And did it help them give better patient care? We also measured their knowledge, skills, and attitudes related to quality and safety competencies. Next slide, please, Colleen. Another way academia can respond to the pandemic is through policy. The National Council of State Boards of Nursing and professional nursing organizations published a policy brief to support academic practice partnerships, which will help the nursing workforce during the pandemic. The policy provides an innovative approach to allow nursing students to supplement and support nursing services in healthcare facilities. They would be working while they're earning college credits. Next slide, please, Colleen. So far, I've discussed strategies that academia can implement to support nursing students, but we also have a duty to support frontline nurses. Nurses are using multiple media outlets to share their experiences with the public. They are telling stories about what they are experiencing while caring for patients during this pandemic. In a press release from the National Nurses United last month, the nursing union tells us to listen to nurses. They tell us that not all nurses have proper personal protective equipment or PPE. Not all hospitals have safe staffing levels. Frontline nurses are working without science-based infection control policies. So we must act immediately. We must support our frontline nurses by giving them the knowledge and the resources to keep themselves safe and healthy while they continue to work in these conditions. Next slide, please, Colleen. So in conclusion, ultimately, the role of academic nursing is to create a highly educated, competent nursing workforce and advance the impact of nursing on patient outcomes and the health and wellness of our nation. And I'd like to end with that statement. My last slide, Colleen, has my contact information if anybody is interested for my reference list or had any questions following. Thank you.
Thank you so much. This was really quite a humbling, roundup, if you will, of the importance of nurses, particularly in a pandemic, and how important it is to recognize this role. If I may, I'd like to ask you, Rayna, to stay on until Shelly has presented her slides so that we can open up for the Q&A at that point. And again, I'll turn now to Shelly for the virtual stage being yours. Go ahead, Shelly. Thank you.
Great, thank you very much. We'll go ahead and start my slides when you're ready. So today, a little bit of a different take on the role of nurses, both at the bedside as well as in the community. I think that that's one of the most incredible things about the nursing role. There's never been a greater time for us as nurses to seek opportunities to do unique and diversified roles across the spectrum of care for folks, whether that's in clinical settings or out in the community. Next slide, please. So I thought I'd start with this slide that really visualizes for you all some photos from 1918, and then the photo on the right is Florence Nightingale during the Crimean War. So we are currently just a couple years beyond the 100-year anniversary of the 1918 Spanish influenza, which, as we know, had significant and wide-sweeping impact in the United States, as well as the world. So about a quarter of the United States and 1/5 of the world was infected during the Spanish influenza, Records estimated 675,000 people in the United States and 20 to 50 million people worldwide died. So we'll compare and contrast that as we talk about pandemics over time. But I thought that given this is the year of the nurse and is being really highlighted by that, I wanted to call attention to how nurses play a pivotal role, not just in peace times, but in times where we're really pushed with major healthcare surge situations. Next slide. So this slide just depicts the pandemics over time. So as I spoke just a moment ago about the 1918 Spanish flu, we then had the Asian flu, the Hong Kong flu, and the one most of us on this call are probably very familiar with is the 2009 H1N1 or swine flu. And you can see the statistics there. So having been accountable for emergency management and preparedness in our health system for several years, we were prepared for the 2009 H1N1 pandemic when it occurred. But I'll tell you, we learned a lot of lessons. We've continued to evolve and really work through all of the related situational things that needed to improve. And here we find ourselves in 2019. So as we think about the statistics so far for 2019, we've got 64 million cases, 13.7 of those are in the United States as of yesterday, and 1.4 million deaths, 270,691 of those in the United States. And as Rayna eloquently mentioned about nurses being at the front lines and the impact to nurses, we do know that worldwide, nurses' deaths surpassed the 1,000 mark. And that's more nurses who died during this current pandemic that we're in from World War I and II put together. So that puts that in perspective. Next slide. So what has been the role of nurse leaders in the health system and in the community? I wanted to spend just a couple moments talking about my role as an emergency management nursing leader for our health system. So these were the varied committees and groups, work groups who have spent time over the last several years continuing to update our assumptions on what were the concerning pathogens out there. I remember in 2019 when we refreshed our pandemic plan, early in the year, it was H7N9 out of China was the most concerning pathogen. Well, fast forward a couple months beyond that refresh of our plan, and here we were with COVID-19. So quickly operationalizing what does it look like to put together your triage plan, your crisis standards of care plan, what would be the transmission route, really applying that then to how we mitigate transmission, whether that's using airborne isolation rooms if they're available, what sort of personal protective equipment we might have available. When we think about some of the challenges we've experienced as nurses in our supply chains, it's pretty significant. Typically, an N95 respirator, which you've heard a lot about during the pandemic, was one of the shortage areas, particularly in the spring, and continues to be a challenge for us as we've progressed through the pandemic. And that's because we live in a very significant just-in-time supply world. So respirators were only used in clinical care for the occasional measles cases or the occasional tuberculosis cases. So there weren't massive numbers of those unless you had done some stockpiling, which we had, and thank goodness for that from a planning perspective for the potential of a pandemic. So many places found themselves woefully capable to be able to work through some of those supply challenges. So that continues today, and we continue to mitigate and work through strategies as we go forward. And then I think we would be amiss to say, you know, that we didn't have impacts to our research missions, right? So just because there's a pandemic doesn't mean that research ends. We really needed to prioritize the clinical trials. Some of those were life and death. How do you maintain and manage those through a pandemic, as well as the education mission, which Rayna spoke about as well. Next slide. So when we think about pandemics and we plan for pandemics, we talk about the 3 S's, the space, so the physical space. You've heard of some places in the United States setting up field hospitals. Some places have space, but they don't have staff. So the second S is staff. That has been predominantly the biggest impact for the nation is healthcare worker staffing, whether that's in long-term care or assisted living or in the healthcare facilities or the ambulatory clinics. Staff has been by far the biggest challenge for us to overcome. So it isn't the bricks and mortar, it was the staff to be able to manage the influx of additional cases. Back in the spring, we saw a lot about stuff. Stuff being the respirators, stuff being ventilators. We've learned a lot in clinical care since the springtime when we saw back east the impacts that were happening there. So these are the 3 S's, and this is what we plan around for the potential of a pandemic and do extensive mitigation strategies and extensive detailed planning around those. Next slide. So I wanted to spend just a couple minutes talking about a little bit more detailed work at the front line. So CDC has a tool that we use to do some preemptive thinking about forecasting. So this was actually some forecasting we did early on, and don't mind the numbers, it's just really illustrative of how we use the tool to really think about an 8-week wave of the pandemic. So I'm giving you this as an example of how nurses led on the front line of how to plan and prepare. And each of these weeks, based upon the volumes and the numbers, had associated mitigation strategies and ideas around how to optimally staff for that situation. So this is just to give you a sense of what that strategy looked like. Next slide. When we think about other ways that nurses lead the hospital incident command structure, we have 10 nurses who actually rotate being on call to lead our incident command. And we need to remember that it isn't just a pandemic that was happening across the country. We all continued to have ice storms and hurricanes and earthquakes and cyber events and all sorts of those things. So really managing multiple issues as they evolved was also an important strategy. And as Rayna mentioned, you know, resilience and building capacity in people, it gets tough when we're asking staff and we're asking leaders to continue to do more and more and more. So these are some examples of some early on implementation components for the pandemic that we had to really give careful thought to. So at what point were we going to require universal masking? At what point would we close down visiting hours? What were our cleaning practices based upon the evidence of this virus and what it was going to take in order to make sure that we could clean properly? What was our ongoing dashboards and understanding of our personal protective equipment? And then we'll talk a little bit towards the end about vaccine. Next slide. This is a pictorial of a dashboard that we created. So again, nurses are involved in informatics. So we quickly were able to put together a dashboard that helped us understand what were our number of COVID positive patients that were in our health system, what were our clinic visits and what was happening with our clinic visits during the pandemic. How about trauma cases? Were we seeing an increase or a decrease in those? We were looking at workforce issues and actually defined what the levels and triggers of those were. Were we in red status with neurosurgeons or were we in green status with family medicine? And then nursing was also a part of that as well. We also tracked our lab turnaround times, and we had a tab that we could click on, and we had the key personal protective equipment items. So the face shield, the mask, the gown, the gloves, and whether we were red, yellow, or green based upon how many days on hand we had on the shelf. So again, another way that nurses were leading in the pandemic. Next slide. And these are just some examples of strategies we had to consider based upon shortages. So really working with our infection preventionists and others to talk about if we were using a respirator, how long could it be worn, so extended use, and then how could we go about perhaps decontaminating that respirator if we needed to. One of the items we were very pleased about was we had reusable gowns, so those could be laundered. Where that was a shortage item for others, it was not for us. But again, it all requires a lot of careful, intentful thought. Next slide. This is a picture of our ultraviolet decontamination strategy. So again, nurses led on this. We partnered with some scientists to really look at the ultraviolet technology and whether or not we could effectively decontaminate our respirators. So this was a scarce resource, and it's still one that we continue to use this process for. So our nurses don't ever put on a respirator over and over and over again. However, what they do is they wear it for an extended period of time within reason between breaks and lunch and things like that. And then they put it into a brown paper bag. You can see it's labeled with their name and the date and how many, the tick mark at the bottom is what number use it is. And so we found that if the staff member is able to get an adequate seal, we usually say between 4 and 6 uses is about the number, but it always goes to be decontaminated, and then you pick up your clean respirators in a white bag. And so it worked out very, very well, and we've had extreme success with being able to do this. So it provided an opportunity for nurses to be involved in research, to make sure that this was an evidence-based practice, that we could put together a tool like this to be able to provide comfort and safety to the staff on the front line, given a scarce resource. Next slide. And then just really some creative things, you know, to help support our community. We had a team called the Swab Squad who went out and did education and hands-on training for doing the nasopharyngeal swab to be able to test for COVID. And so put together demonstration videos and checklists and practice tools, and just a phenomenal amount of innovation and ideas and really outreach with the communities. Next slide. One of the topics I wanted to spend just a couple minutes on was really our ability to do some early response in the COVID outbreak, as we were asked by the federal government to support individuals, Americans being repatriated from Wuhan, China, as well as the Diamond Princess cruise ship. Next slide. So these 2 missions, the first was 57 Americans who needed quarantine. So quarantine is separating well people and observing them for symptom onset, which in the case of this pathogen, the time frame for that was 14 days. So we surrounded them with support services, identified a safe location, work through all of the logistics of providing, you know, safety and exercise, as well as food and all those sorts of things. But again, it was a great opportunity for many of us as nurses to engage with and be involved to help. And then we also had the opportunity to care for 15 Americans from the Diamond Princess cruise ship. And this is where it got a little bit more complicated, because some of them actually had tested positive, but they weren't sick enough to need hospital admission. So we were able to monitor them closely, and those that then required hospital admission were able to be quickly moved for the care level that they need. And then beyond that, we began to see, you know, once those 2 missions ended and those folks all went home, we were able to see, you know, case counts starting to mount back east, and the rest is history, so to speak. Next slide, please. These are just some photos of our mission. So we actually had them come into the airport hangar, and we worked through doing a quick assessment with them, identifying phone numbers and how we would communicate. They all had to be carefully monitored several times per day, and CDC and others were on site with us. Next slide. And this is a picture of Camp Ashland, which is where we had the 54 Americans housed, and we just really supported them and surrounded them with the support resources that they needed. Next slide. This is a visual of our Joint Information Centers. So really the wonderful opportunity to partner with lots of federal agencies on these missions. And we did a daily briefing with lots of different stakeholders. Again, I was able to lead that briefing, and it was a fun nursing leadership opportunity. Next slide. This is just a visual of what our quarantine spaces look like. Next slide. The last thing I want to spend a little bit of time on is our community outreach. So this is a risk mitigation framework from the National Institute of Occupational Safety and Health, which is an agency within the CDC, Centers for Disease Control. And it actually talks you through how to implement the framework, going from the most effective control to the least effective control. And it's not that any of them aren't important, they're all equally important. It's just some are more effective than others. So when we think about elimination and substitution, those were very hard to implement because we can't physically remove the hazard or replace the hazard. Once we get a vaccine, we'll be able to somewhat effectively be able to start working on physical removal of the hazard or replacement. But until then, we're sort of left with the rest of these controls, engineering, administrative, and PPE. Next slide. So as we did outreach in the community, we were able to have really a great team who was able to go out to the meatpacking plants. I've grown up in agriculture my whole life, so this was fun to be able to go out and serve as an infection prevention expert in these meatpacking plants, work with the leadership, work with the workforce, and I'll share these slides with you all so that you can look at some of this detail more clearly. But we were able to create some playbooks using that framework for what would be the mitigation strategies to consider implementation in these meatpacking plants, and I've given you the link there if any of the playbooks might be of interest to you. We also took a holistic view, and not just with the plant leaders, but also with the workforce, and did a workforce survey so that we could better understand the needs of the frontline workforce in meatpacking plants, which many of them, lots of different diverse cultures, language barriers, etc. Next slide. We did outreach in schools using the similar framework, really suggestions about de-densifying classrooms, hybrid models, using barriers, cleaning practices principles, had some data that we did a side-by-side comparison of 13 different countries, bringing kids back into the school environment and what were their successes and what did they learn, and then created a playbook for schools. Next slide. Finally, we spent time in long-term care. Long-term care is one of the most underserved group of healthcare facilities in this COVID pandemic, and we've seen really a significant number of illness and death in our long-term care facilities. Again, these were facilities where some of the workforce did not have respiratory protection programs in place. PPE was hard to come by to begin with. And then we had vulnerable adults. So I think as we were able to do some of these site visits, it was very heartwarming to be able to provide just-in-time education and really give them some core knowledge to be able to reduce transmission of the virus within their facilities and cohort groups, etc. Next slide. And then just some other technical assistance as well. And again, those playbooks are available if you're interested. Court system, the Big Ten, 4-H was big for me. So really helping people operationalize how to get their fairs back open. Next slide. And then fast forwarding now to where we're at today. I mentioned the statistics earlier, so I won't spend time on that. The left visual is the last 14 days of new cases per million, and on the right is new deaths per million. And I'm not proud of the fact that Douglas County, Nebraska is the 5th highest county on the left with the highest number of new cases. So we continue to struggle here in our state to really implement effective directed health measures in meaningful ways. And again, this is where I think nursing leads on communication and education. Next slide. And then finally, have had the opportunity to work on implementing a medical emergency operations center for the healthcare systems across our state and in the region to be able to communicate, coordinate, collaborate in a meaningful way, share bed data, move patients from one region to another, develop a transfer center concept, and really do statewide planning and mitigation in a meaningful way. So lots of different stakeholders involved here, from healthcare to associations to state representatives to federal representatives, etc. Next slide. And this is just a little bit more detail about what each of those stakeholders brought when it came to operationalizing the Medical Emergency Operations Center. Next slide. Finally, I want to leave you with a little bit to think about related to the vaccine strategy. Again, we have a couple of hopeful vaccines. In fact, the logistics and the planning around vaccine delivery is significant. In many cases, nursing is leading on that in our public communities and working in partnership with our public health. We're putting together just significant logistics around how do we tier the healthcare workers in a meaningful way based upon the amount that will be allocated to each state and each region and each county. Some of this drug needs to be kept very cold until it's about to be delivered. So in states like Nebraska with significant rural locations, it adds a dimension of complexity again. And I also think a big issue right now that healthcare should lead on is concern for vaccine hesitancy. I think there is worry out there, unfounded a bit, of sort of the speed at which vaccine has been brought to market. I think we've been doing parallel processing versus what in past has been linear. And so I think they've done a great job, and it's going to be up to all of us to really forward push and lead on safety and efficacy of vaccine. Otherwise, I fear that we're not going to be able to properly mitigate this pandemic adequately if we have folks who are tremendously concerned about getting the vaccine. So lots more to come on that, I'm sure. Next slide. I think that's my last slide. Thank you.
Thank you very much, Shelly. And, you know, I'm left here speechless, almost thinking, where do I begin with questions? So it's time for all of us to, you know, think in terms of questions. And I will remind our audience that they can put their questions in the Q&A tab at the bottom of their screen. So perhaps I'll start maybe with Rayna and try to bring together a few of the questions that we received. And that is, number one, how do students respond to being a graduate nurse during a pandemic? And in that respect also, how have your assessment of learning changed? And perhaps even more specific, how has the curriculum changed to foster self-care?
Okay, I hear three questions there, so I would like to start with fostering self-care, if that's okay.
Absolutely.
What we have done is, in response to the COVID pandemic, nursing education was forced to pivot quickly, and most of our content is being delivered in an online environment. So students are no longer coming to campus. They're participating in either synchronous or asynchronous online activities, which can lead to a sedentary lifestyle when we're not up and moving around and we're spending a lot of time in front of the computer. So some of the things that we're doing at the university to increase self-care and increase physical activity is offering fitness classes online through social media platforms such as Instagram Live. So students can participate in physical fitness activities instead of having to go to the recreation center. They could do it wherever they are geographically. And then specifically within our College of Nursing and the nursing students, we've developed a committee which is going to put together a learning environment or social environment that students will be able to come together and have that socialization that they're missing from not coming to campus as often. And what I mean by that, an example, typically if students were coming into my classroom, they would come 5 or 10 minutes before class would start and have social interaction and have discussions, and now they're not having that any longer, and that's having an impact on their health and wellness. So the College of Nursing is putting together an online platform that will offer that to students, so they'll still have that socialization and opportunity. So those are two examples of how we're making changes to increase self-care for our students. And one of the questions, I believe, was how are we measuring outcomes? Or would you be able to repeat, Kathleen? I apologize.
Yes. How have your assessment of learning changed?
So if I can speak to how we've changed assessment of learning, and specific to the exemplar that I used in my presentation, we are offering a virtual online clinical practicum for the students. And the way that I am changing my assessment is really looking at the students' demonstration of how they apply the knowledge they've learned throughout the program into decision-making as a nurse. So we utilize more case studies, we utilize online discussion forums and expect them to engage with content and each other. And then I can analyze how they're thinking and making sure that they're applying the knowledge appropriately.
Thank you very much. Turning to Shelly, I mean, you referenced the 3 S's. Could you maybe address changes in the trend of nursing students as well as professionals immigrating to the US? Now, we know what has happened pre-COVID. What do you think is likely to happen post-COVID? And then in the same vein, do you see any changes, and Rayna, you might chip in here, any changes in the enrollment trends, or do you anticipate any changes there?
Yeah, I think we've long had established international collaborations in the academic world, so I don't really see those changing. I do think they've been hindered by this because of the inability to move readily back and forth, but in some ways those have been continued to be fostered in a virtual way. But I guess I don't see much in the way of impact to those as we move forward. Hopefully we'll be able to pick those back up where we left off. But I'll let Rayna speak to the nursing program enrollment component.
The enrollment component, thank you, is such a timely question. I was on a call yesterday with a national academic task force, and this was part of the discussion, and it really was variable depending on where programs were in the nation. It appeared some have witnessed a decrease in enrollment, specifically in their graduate programs, and some have not. Some have seen an increase in applications. So that will be something interesting that we should trend as a profession and really look if we can understand some of the reasons that we see the differences.
So perhaps, and again, this might be more directed towards Shelly. One of our members raised the issue that there's been some talk about the fact that if COVID cases rise to a certain point before vaccination starts, this will cut into the effectiveness of the vaccine. Is that true, or is there a source that you can recommend that would enlighten that question?
Well, I've not heard that, so I wouldn't have a reference for that. I can say that there's a lot of things. Obviously, if anyone tells you they have the answers to all of it, they're probably not being very honest these days. We don't know how long immunity lasts. We don't know many of the long-term outcomes of healthcare and what that's going to look like for years to come for people who have had COVID. I do think, though, again, I am worried about vaccine hesitancy, not for the purpose of more people having COVID and not needing it. And in fact, I think there's a lot of conversation right now about whether or not people who have had COVID should get the vaccine. So I'm hearing more and more people say they think they should. But again, really the expert opinion, it sort of changes daily, and we have to just sort of keep up with all of that. So I've not heard any sort of objective information about that question or seen any references to that would have any impact.
And in terms of the nursing, how is the overtime hours being managed?
Yeah, for us, we're trying to utilize a lot more folks who maybe haven't been at the bedside for a while to help with extra pair of hands. Not that they're doing the medication or the assessment or anything like that, but just helping with general cares, knowing how short, you know, the frontline staff is. So we're seeing a lot of people stepping up to really add their capabilities to the direct clinical care, which is wonderful. There is, in many places, mandatory overtime. So within reason, I think that can be balanced. Again, much to what Rayna said, you know, really encouraging the self-care, making sure that people get respite in a safe location so they can remove their personal protective equipment, have, you know, a appropriate break. We are seeing really encouragement of people being maybe interested more so in healthcare careers. We've actually extended an offer for anybody who wants to join the team to be a personal protective equipment extender. And what that means is we teach you the safety components of putting on and taking off your personal protective equipment. And then they're the ones really working with the clinical staff to help coach and support them and call the question, you know, stop, you know, if they miss a step, and really trying to help keep everybody safe. So that's been sort of an enlightening kind of positive movement forward.
And it's interesting because, you know, over the few months, because it is actually a few months, it feels like an eternity, of course, but a lot has been learned in terms of, you know, protection, but also the, you know, the caregiving, if in that respect. But, you know, I think, and this is a question to both of you, you know, the crucial part here, the crucial elements that the nursing staff is providing to healthcare, and particularly dealing with the pandemic, is, as Rayna, you mentioned, the really how the toll that this is taking on the profession, if you will. And then you juxtapose that with parts of the population which is still perhaps downplaying the gravity of it, the importance of how damaging this disease is. How do you help your students and or your nursing teams navigate this?
So I think your point is spot on. I think many of us live in areas where there aren't mandatory mask mandates, that we see risky behavior, and I do think that's disappointing, you know, to us as nurses. But what we also remind ourselves of is, what do we have control over, right? Who can we coach? Who can we educate? You know, turning that momentum of disappointment maybe into really an opportunity to do more education and outreach, and try to do that in a meaningful way.
Right, right. And Rayna, you have also been confronted with that with regard to your students.
And I agree with what Shelly said, and just increasing education, I think, is going to be the best impact and the best approach that we can take, both with educating students on what they are going to face when they become the professional nurse, and educating the professional nurses on how to handle those types of situations. At USF, we did receive a generous donation from Mr. Kotak, and we're putting together a program for frontline nurses that will address just this situation.
Right.
So,
yeah. It's interesting. I mean, you know, the question then becomes, and I'm jumping here ahead, when, let's say, a majority of the population is vaccinated, yeah, there is a degree of comfort in the general population that even if the virus hasn't disappeared, we can fight it in a way. Will the educational process for the population continue or not? And that's a risk, right? That, you know, people get slack and we forget about it, and, you know, until the next big onslaught comes about.
and I agree. And then in addition to the points that you're making, Kathleen, I think that we need to do a better job educating the public to understand what's credible information that they are reading and that they are receiving, and to really understand what scientific information is and how it differs from hearsay information, for example. And I think that would really help the nurses and the healthcare professionals as we're doing our education, so that the general population understands what's credible and what is not.
Right, right. And the general population understands how important it is to support nurses. You know, for the first few months here in New York, and I'm sure in other areas as well, you had at 7 p.m. music essentially breaking out, and it was really quite moving. Yeah. Well, we are literally at the end of this session. I want to thank you again for your time. I wish that we could continue for quite a while, because we do have quite a few questions that I have not been able to address because of the time constraint. But Rayna, Shelly, thank you ever so much. Those were so insightful, you know, comments, and certainly eye-openers. And I really thank you for spending time with us today. And I do hope that, you know, we can maybe think of another session just as an update, you know, where we can cry victory against this pandemic. Thank you again. And before we adjourn, just turning to our audience, I'd just like to mention that we have this webcast being recorded along with the prior ones, so you can find it out on our website. And also another thing that is quite important, and that is the fact that a feature of the David R. Kotok Global Healthcare Series is that David has established a very generous matching donation challenge. So any donation that you would make today would be matched dollar for dollar. And this is important because it goes directly towards bringing high quality to the content that we have in terms of as a public service. And that's really going through 2021. So you can find these replays, membership, even if you're interested, and take advantage of this donation match on our website, which is www.interdependence.org. And as we conclude, I would like to ask you for yet another 60 seconds worth of your time and to respond to our audience survey. That's always so helpful for us to essentially improve on our programming. So with that, thank you again. Thank you, Rayna. Thank you, Shelly. And we adjourn. Have a great afternoon. Bye-bye.